Bismillahirrahmanirrahim. I am very much thankful to Professor for giving me this opportunity to discuss with you people this new surgical technique. But this is new because it's about 20 years that this procedure is in practice. And today we are going to cover the major MIS surgical technique, that is the MIS transpedicular fixation and MIS T-lift. And basically to date, in the last 20 years, only these two procedures have proved their efficacy. Although a lot of the techniques have been tried, but these two are the main. Initially, I will give you an overview of the anatomy. So first of all, what are the prerequisites to do an MIS surgery? The prerequisites are basic knowledge of the normal anatomy. Just hold for a second. First of all, what are the prerequisites for this MIS surgery? The number one is the basic knowledge of the normal anatomy. Before doing any procedure, although the knowledge of the normal anatomy is important, but regarding the MIS surgery, it's of utmost importance. And the second one is that you must be familiar with the open surgical technique. Because in the beginning or during the procedure, there are many steps when you have to switch to the open surgical technique. So before doing the minimal invasive surgery, you people must be familiar or expert with the open surgical technique. And on these 2 points, I would like to have the comments from Shahzad Saab, that what he thinks about the familiarization with the open surgical technique before moving on to the MIS surgery. Sir.
Without knowing anatomy and at least, I think so, 100 cases of open surgical technique, you cannot move to this micro technique or this minimally invasive technique, because it is very essential for you to have experienced where is the facet, where is the pedicle, where are the laminas before you're going for this blind procedure with the help of radiographs.
Thank you, sir.
So it must be learned before you go for this minimally invasive technique.
So coming to the basic anatomy of the lumbar spine, especially for the transpedicular screw fixation, I would like to make you familiarize with the muscles of the back. Among them, the two muscles, they are of the utmost importance. Among them is the erector spinae muscle. Here you can see it has 3 parts. I will discuss it with you in the next slide. And the second one is the multifidus muscle. This erector spinae muscle, it has 3 components: the iliocostalis, the longissimus, and the spinalis. While the lumbar spine muscles, they are divided into the 3 layers: the superficial one, the intermediate, and the deep layer. The superficial layer is formed actually by the thoracolumbar fascia, which is the continuation or the origin of the erector spinae muscles. Along with that, this intermediate muscle, that is the multifidus muscle, it is the most important muscles of the lumbar spine. And it includes the intermediate layer, while the deep layer, it composed of the intertransversi muscle or interspinalis muscle. The erector spinae muscle, having the 3 components, they are going to originate from the same origin of the multifidus muscle, which I will going to show you in the next slide. The main action of this erector spinae muscle is that it helps in the trunk extension when both the erector spinae, they are in action, or it can result in the ipsilateral flexion and the rotation when the unilateral contraction comes into play. Here comes the most important muscle of the lumbar spine. It extends up to the thoracic and even the cervical spine as well. This is the multifidus muscle. It's going to originate from the transverse processes of the vertebra and insert into the spinous processes 2 to 4 vertebrae superior to its origin. So it's moved like from here to here to here throughout the lumbar spine. One of the most important muscle that helps in the lumbar spine stability, because it is a local muscle and it controls the fine movement of the adjacent vertebra. The deeper muscles, these are the interspinalis and intertransversi muscle. They are of not that much important. They're just helpful in the local movement of the adjacent vertebra, and they are going to origin from the transverse processes and insert into the adjacent transverse process. After this brief overview of the muscular anatomy, when you are going to create your channel for the transpedicular screws, you must know your landmarks, that where you are going to enter. For that, in the lumbar spine, in this slide, you can see that this is the multifidus muscle, and here is the longissimus muscle. The plane between this multifidus muscle and the longissimus muscle is very important, because this is the plane through which we approach to the facet joint when we are going to proceed for the T-leaf procedure. So I'm going to repeat again for you people that the multifidus muscle and the longissimus muscle, the plane between these two muscles will lead us to the facet joint, and this facet joint is the target in the MIS T-leaf. Two bony landmarks for the transpedicular screw fixation. The one is the Miminally process, which is just situated on the lateral aspect of the superior facet. And the second thing is the pars. This pars, the anatomy of the pars is of utmost importance in the transpedicular screw fixation. It is also called as the pars interarticularis. This is a part of the vertebra that is located between the superior and the inferior articular processes of the facet joint. In the transverse plane, it lies between the lamina and the pedicle. So here, this area is the facet joint, this is the lamina, and here is the pars, which is going to connect the lamina with the pedicle. The anatomical pulse for the transpedicular screw insertion, we have to meet 3 points. The number one, this line that is passing through the mid of the transverse process. The other one that is from the just below and lateral to the superior articular facet, or just below the mammillary process. And the third one from the pars. The point where these 3 lines join, this is our entry point. And this is important for the open technique, but when you are doing the MIS, you have to focus on the shadow of the pedicle on the C-arm. Now, when in the dorsal spine, the entry point, it varies as we move from D1 to D12. But this uniformly, consensually decided point is the transpedicular fixation point for the dorsal spine, and it is 3 millimeter caudal. From where? From the junction of the transverse process and the lateral part of the superior articulating facet. So this is a uniform entry point for all the dorsal spine vertebra when you are going to do the open technique. But for the MIS, you have to rely on your imaging. You have to look for the pedicle shadow. What I think that this slide is the essence of the MIS surgery. The appropriate usage of the C-arm. And after reading for the MIS in the last 2-3 weeks, I realized that why Professor was insisting for the residents, for our doctors to use the C-arm. Because it counts 50% of the success of MIS surgery is depending upon the appropriate usage of the C-arm. Your C-arm man is the main key in the success of this MIS surgery, because he is the person who is going to show you where you are going to operate. If there is any slight movement of the C-arm, you can be end up in the disaster. Like this, the X-ray of the lumbar spine, which you are going to see on the screens on the right side, also on the left side, it is having absolutely very good marking, like the pedicle, like the spinous process, the psoas muscle, this and that. But whether that this is an appropriate anteroposterior AP view X-ray, I think no, because there are a lot of double shadowing. So what is an accurate AP X-ray? AP X-ray is that one is accurate in which there is equidistant from the pedicle. The spinous process is having the equidistance from both the pedicles, number one. Number two, the upper end plates, the anterior and the posterior rim, both they superimpose to give you a single line shadow. There should be no double shadowing of the superior end plate of the corresponding vertebra, and the spinous process, it should be at an equidistance from both the pedicles. An overview for you people of the thoracolumbar classification of the AO spine. There are three types, type A, B, and the C. In the type A, these are the compression injuries in which the A4 is the complete burst, the A3 is the incomplete burst, A2 is the split one, and A1 is the wedge. And this in the C, this translational injury you have seen in your ward many times. So there are various kind of the fixation approaches that can be done with the help of the MIS. Among the posterior one, as I already mentioned, this is the pedicle screw fixation, and the anterior one are the interbody fusion techniques. There is a long list of the interbody fusion techniques, but till now only the T-leaf, that is the transforaminal lumbar interbody fusion, has been done successfully. The iliosacral percutaneous fixation have been tried with the help of the endoscope. The cage fixations have been tried. And one more thing, that is this MIS is working as an adjunctive procedure. Like you are doing the open transforaminal, or you are doing the open lateral lumbar interbody fusion, but you do the percutaneous posterior fixation. So wherever you get the chance to reduce the muscle trauma, you should avail this opportunity of of doing the MIS. Over the years, there is a vast range of implants that are available around the globe, but the basic technique of the implant remains the same. Initially, the retractors, they were of huge sizes, they were cumbersome to use during the surgery, but now they are reduced just to the small tubes. I will share with you the few recent papers in the end of this presentation, which will emphasize on the neuronavigation, the intraoperative CT, and even the robot assistance for the MIS surgery. Now, what are the indications for the MIS TP fixation? Number one, the spinal instability. So, Dr. Irfan, yeah. So, what do you think that what kind of the spinal instability you can use the MIS transpedicular fixation?
We can sir use MIS in trauma.
Yes.
In old ages like degenerative spine diseases, and
what do you think? What does the mean of the spinal instability? Can you revise it for your fellows that what spine is unstable? Just a revision for you people. Do you remember three columns?
Yes, sir. Spinal instability can be evaluated by three-column theory, if which involves anterior column, which anterior half of vertebral body, and middle column, in which posterior half of the vertebral body and the posterior elements of the spine, and the third column, posterior column, in which spinous process and spinous processes are involved.
So it means that if the two columns of these three columns are involved, then the spine is unstable.
Yes, sir.
Yes, MIS surgery can be used in any kind of the spinal instability, whether it is due to trauma, it is due to tumor, it is due to infection, or even due to the degenerative spondylolisthesis or any other pathology.
Okay, sir.
So the next one is that this MIS TP fixation can be used in conjunction with the interbody fusions. I will show you a few examples in which they have done the long open lateral lumbar interbody fusion, and then later on they use the MIS TP fixation to avoid the muscle trauma where they can. But one big question on the MIS TP fixation is that this is just an internal bracing in the absence of the bony orthodesis. So is Dr. Madhya here?
Yes, sir.
Yeah. So what you get from this line, Madhya, that internal bracing in the absence of the bony orthodesis.
So that means we are just fixing the spine by rods and plates without intervening any, without applying any orthostatic implant, for example, the spacers and bony bony grafts.
You must remember many times Professor Saab and Shahzad Saab have told during the round and even during the surgery that did you place the graft? You remember this thing? Many times during the TP fixation, during the open TP fixation, during the craniovertebral fixation, he was always adamant to this thing that did you place the graft?
Yes,
So,
sir.
bony orthodesis. It means this the big question on this TP fixation is that it is a very good internal bracing with the minimal muscle trauma, but there is no bony fusion. You're just going to put the screws. The final fixation, the final fusion, it depends upon the bony orthodesis. Recently, in the last few years, the speculum retractor, they have been invented, which can be used for the preparation of the posterolateral area of the screws for the fusion bed preparation, and you can use the autologous bone or other bone graft material on that places to enhance the bony orthodesis. So coming to the operative technique and the operative steps of this MIS transpedicular fixation. So first of all, you have to get the AP and the lateral view to confirm your vertebra which you are going to instrument. The next, you have to do the midline, the lateral pedicular and interpedicular lines on the skin. And there is a just repetition that what is an absolute precise AP view, which is showing that the spinous process is equidistant between the both pedicles, number one. And number two, the anterior and the posterior rim of the upper end of the vertebral body, it's superimposed to a single line. So the patient has been anesthetized, is in the prone position on the Wilson frame, and the midline is marked. So here is the X-ray. When you are going to mark the midline, you must be confirmed that it's over the spinous processes. Then the interpedicular lines, they are marked, the one and the second one. This is your final incision that you have done with the help of the CM. Then the patient is prepared, and you will reconfirm your incision with the help of the Jamshedi needle. This one is the Jamshedi needle. Do you think, Zubair, that either this should be our incision? Zubair,
yes, sir.
Either, what do you think that either we will place incision over here or here?
No, sir. Incision should be lateral to lateral border of pedicle. It means it should be far from lateral border of pedicle.
Very good. So when you are going to place your incision, you should keep in your mind that it must be a bit lateral, 1 to 2 centimeter from the lateral border of the pedicle, so that you can create an appropriate trajectory. So this point is clear to everyone?
Yes, sir.
Okay. So the next step, I mentioned that 50% of MIS is depending upon the CM, and the 50% of MIS transpedicular fixation is depending upon this docking of the Jamshedi needle into the pedicle. You took extra time, you took more time, but your pilot hole should be absolutely perfect, because this is the going to, if you have done the complete, the accurate docking of your Jamshedi needle, then you are done with the procedure. The rest is just few minutes. So take your time in getting an appropriate X-ray, and the second one in the docking of this Jamshedi needle. So what you are going to do, that you have planned your incision a few centimeter lateral to the lateral aspect of the pedicle. You will incise the skin, the subcutaneous tissue, and the fascia. And then manually, you will put your Jamshedi needle inside and find the transverse process. You will walk on the transverse process and then take a step to reach the superior articular facet and confirm your location with the help of the CM. So if this is the pedicle, so what would be your ideal location of entry of this Jamshedi needle? It should be in the upper outer quadrant of the pedicle. When you are creating this transpedicular channel, under the fluoroscopic guidance, you must keep in your mind that it should be in the upper outer quadrant. It should not touch the medial wall of the pedicle. Both the Jamshedi needle, they have been placed. And one more important point here is that when you have docked your Jamshedi needle into the upper outer quadrant of the pedicle, then you are going to mallet it. You are going to be up to 30 millimeter. But you must be careful that you should not advance the medial border. You should not cross the medial border of the pedicle at least for the 3 centimeter. Why? You will be going to see in the next slide. So here you have started your malleting, you have into the middle part of the pedicle, but this should not be done. This should not be done before the 30 millimeter, before the 3 centimeter. Irfan is a bit looking confused because I think he's just woke up from sleep. So this next slide, this is for Irfan. So have a close eye, Irfan, on all these sequences that you have started docking the Jamshedi needle. Here, you are going to mallet it for the 30 millimeter. You are passing through the pedicle. And on this view, when you are done with the 30 millimeter, you have crossed the pedicle and reached the vertebral body. Afterwards, there is no harm in moving your Jamshedi needle medial or lateral once you are in the vertebral body. So is that clear to you, Irfan?
Yes, sir.
Okay. So after the Jamshedi needle has been docked, the stellate is removed, and the guide wires, they are passed into the pedicle. Jamshedi needle is removed, the guide wires, they are in place, and with the help of the serial dilators, the paraspinal muscles, they are dilated with the help of initially the small dilator and then with the larger dilator. Here, what is the image that you are going to see on your lateral radiographs, that the needle is in, guide wires, they are in place, and this is the smaller dilator. The smaller dilator, it should be docked at the same place where the needle was. And there should not be any soft tissue between the entry point and the dilator. So the small and the larger dilator, they are in place. The smaller dilator is been removed, and then the pedicle and the proximal half of the vertebral body, they are tapped with the cannulated tap. So here you can see that the tap has been removed, the guide wire is in place, and the appropriate length screw along with its tubular retractor is inserted. So what happened here, Zubair? Where can you see the radiograph? With us, then Dil, can you see anything on this X-ray?
Yes, sir, I can see the guide wire being passed through the initial trocar into the vertebral body, and I think it has gone past the vertebral body. Or
oh, this guide wire has actually crossed the anterior vertebral body limit.
yes, sir. Yes, sir.
This is a learning point for all of you, that when you are doing this procedure, especially in the first few cases, you should do the X-rays at every step. Or if you feel that there is an abnormal movement of the guide wire. So violate insertion is confirmed fluoroscopically with the, it can violate the anterior vertebral body, or even it can be pulled out prematurely. All the 4 screws, they are in place with the tubular retractors, and the upper bars of these tubular retractors, it has been removed. There are a variety of the various the rod systems. Initially, the rod system which were developed, they are very large and very disturbing for the surgeon. But with the passage of time, they have developed such smart rod system that it can be used, that the same incision can be used for that one. So these are the 2 X-rays which are showing you that the rod has been in place. And Dr. Zubair, can you guide us that which one is the better X-ray or the better position of the rod?
Sir, X-ray on my right side of the screen is the better one, sir.
This one?
Because no, sir, the next one. Because
This one.
yes, sir. Here there is better engagement of because the rod should engage with the screw cap. This is the most important point, sir.
But can you see that there is only a few millimeter of the rod left on the upper screw?
Sir, looks like.
So this rod is much better than this one. So the point of showing you these X-rays that you are going to confirm your rod position with the help of the imaging. Do it again and again, because the appropriate positioning of the rod is one of the major steps of this MIS surgery. This is the final position of the fixation, the wound. Now, coming to the next technique, that is the MIS TLIF, that is the transforaminal lumbar interbody fusion technique. So what are the indications for this MIS TLIF? The indications are the same as that of the open TLIF, like spondylolisthesis or the recurrent lumbar disc herniation with mechanical back pain or with radiculopathy, or in the cases where there is the post-discectomy intervertebral body collapse with foraminal stenosis, pseudoorthosis, degenerative disc diseases, the focal spinal deformity up to the 3 segments, or the post-laminectomy kyphosis. So all the indications which are fitting the criteria of open TLIF, the MIS TLIF can be done. This procedure have been used for the last 10 to 15 years. But at present, there is no class 1 study to prove that MIS TLIF is superior than the open TLIF. So the most senior resident, Dr. Adil, are you with us?
Yes, sir.
So this image is just for your brainstorming, that the arrows are showing the various interbody fusion techniques, procedures in which you remove the disc and you do the fusion between the vertebral bodies. So what do you think that this arrow is showing which procedure? Just you have to name the procedure. We are not going to go in detail of all this procedure. We will just discuss the MIS TLIF. So this arrow is pointing towards the
Translaminar, sir, lamina.
What would be the appropriate word for this procedure? As I mentioned earlier, that these all arrows are the interbody fusion techniques. Like I gave you a hint, like this one is the TLIF. That is the transforaminal lumbar interbody fusion technique. When you are going to do the TLIF, you will approach from here. You have seen this procedure.
Facet, sir, transfacet.
No.
It's PLIF, sir. It's PLIF.
Yes, yes. This one is the PLIF, the posterior lumbar interbody fusion technique. This one I mentioned is the TLIF.
TLIF. Yes.
This one.
Sir, it may be OLIF or
you have seen this
extreme lateral मेरे ख्याल में, या OLIF हो सकता है.
OLIF next one. OLIF is next one.
Yes, okay. Adil is right that OLIF is this one. Then this procedure we are routinely doing this procedure in our ward. The cage fixation, the retroperitoneal. This one is the lateral lumbar interbody fusion technique. And this one must be the favorite of Dr. Irfan. He like the complicated and the innovative procedures. Irfan.
Yes, sir. Yes, ALIF, anterior lumbar interbody
Yes, very good. So here you can have a well appreciation of the all the procedures that where we are going to do, where we are going to move, like PLIF, posterior lumbar interbody fusion, TLIF, the transforaminal lumbar interbody fusion, the lateral lumbar interbody fusion through the source or the behind the source, and the OLIF that you are going to just anterior to the source, and the ALIF procedure. So coming to the operative technique of MIS TLIF. Has moved from open to the minimal invasive. In the open technique, you have to do the excessive muscle work, but nowadays you just place a tubular retractor and you're done with the procedure. Before moving on to the operative technique, I would like to have your concept of the exiting nerve root and the traversing nerve root. Yes, this must be answered by senior resident.
So, and traversing, so traversing nerve root is the one which is traversing through the across the foramina and going to, yes,
Yes, you have a better idea
Yes.
than Adil or Madhya.
It's a sir, yes, sir. If we take the example of vertebra L3 and L4, and
Yes,
if we
this
look
is L3,
at
this
the,
is L4.
yes,
Okay.
okay, if we are looking at the L3 L4 disc, then the nerve which is passing between the L3 and 4 intervertebral foramen, this is the क्या कहते हैं, traversing, sorry, exiting nerve.
Okay. I
Exiting nerve.
make it easy for you. You have to final
Okay.
between two nerves. Is this nerve and
This is,
what is this nerve? Okay.
sir, this is L3 nerve is the exiting nerve and L4 is the traversing nerve जो कि L3 L4 से pass कर रही है.
Okay.
Yes.
Adil, you have any reservation or you are agree with the?
no, sir. I think Madhya is right.
Okay. So this picture will make you this thing more clear, that whenever you are going to have the L3, L4 disc prolapse or the disc prolapse, it will involve the L4 nerve root. You're going to have the symptoms of the L4 because the L3 nerve root, it exits above. Am I clear?
Yes, sir.
Okay. So keeping this thing in your mind, we are going to move to another triangle, which is the key to do a T-leaf procedure. That is the Cambin's triangle. So, Zubair, do you have any idea of the boundaries of the Cambin's triangle? So it's completely shown in the picture.
Yes, sir, it's already
T-leaf
shown.
through this. Yes, Zubair.
Sir, it is lateral margin, sir. It is the lower facet of upper vertebrae and inferior facet of upper vertebrae and superior facet of lower vertebrae, sir. And lamina.
You have to use the word. You have to use the nerves. Keep in mind that I have discussed with you the exiting and the traversing nerve roots. So these nerve roots are going to make the boundaries of this Cambin triangle.
Sir, I couldn't understand your question, sir.
Okay.
Exiting nerve roots.
Then read this one first. At the medial boundary of this Cambin's triangle, I will show you a few more pictures of this Cambin triangles from all the angles. This you are going to see from the side. I will show you from the top, from the bottom, from all the views. So you must be clear about this Cambin's triangle. So just first read this thing, that medially this triangle is bounded by the traversing nerve root. Here you have seen this one, the traversing nerve root, and laterally by the exiting nerve root, and the base is by the inferior pedicle. So Zubair, are you clear about it now?
Yes, sir.
And have a look at this one as well. So you're seeing what you're seeing from the top. This is the cranial one. This is the caudal, the posterior from where we are going to approach to the patient, and the anterior one. This is the exiting nerve root, and here is the Campbell's triangle. This 3D picture is going to show you the complete view of the open T-leaf, in which this is the exiting nerve root, this is the traversing nerve root, the disc, and the part of the inferior facet of the upper vertebra and the superior facet of the lower vertebra have been removed, along with some portion of the lamina as well. So, Irfan, can you repeat the boundaries of this Campbell's triangle for us?
Yes, sir.
Yes, please. This you are showing, going to view from the side, that this nerve is the
exiting nerve root, sir.
okay. This would be the inferior, the superior base of the pedicle, and here will be the traversing nerve root.
Yes, sir.
This is for Irfan again. Here is the exiting nerve root,
Yes, sir.
nerve root, and the superior end plate or the upper border of the lower pedicle.
Yes, sir.
So this Campbell's triangle is clear to everyone.
Yes, sir.
Is
Yes, sir.
silent for the last 1.5 hours, I think 1 hour. Nasirul Haq, are you with us?
Yes, sir. I'm with you.
Your voice is quite low. I think you are doing work in the ICU.
Sir, sitting in the room, having.
Okay.
Yeah.
Then can you tell us that which one is this procedure and this procedure? Just can you name both of them? We have discussed this previously in the previous slides.
Yes, sir. The upper box, sir,
Yes.
is a posterior P-leaf.
Yes, posterior lumbar interbody.
Interbody fix. Yes, sir. And this one is probably T-leaf, sir.
T-leaf.
Foraminal.
Okay, good. So various retractor system, as I mentioned, were developed in the MIS transpedicular screws. The same is the case with the MIS T-leaf. Initially, this huge retractor system was used. I will show you one of the research paper in which this retractor system was used. But later, nowadays, this tubular system or the Viper system, they are in practice. In 2006, the Holly et al. Presented his paper of MIS T-leaf technique, and he proved that it has the same efficacy as that of the open one. So this one, he used the tubular system, but at that time he was having such cumbersome. You can see that this was the MIS transpedicular screw tubular system, and this one he is going to do the MIS T-leaf. You will get these points in the next slides when you are done with the operative technique of this procedure. So initially I will narrate the steps of the MIS T-leaf, then I'm going to show you the diagrammatic views. The patient is positioned in the prone. The incision is targeted with the help of the fluoroscopy. And if you are going to do the two leaf or the unilateral, you will going to mark the incision 3 centimeter later. And now the reminder for you people, the plane that I mentioned earlier between the multifidus and the longissimus muscle. This is called as the Wills plane. And you will do the sharp incision of the fascia and then the blunt dissection of this Wills plane to create the space between the multifidus and longissimus to reach the facet. And then the tubular dilator retractors they are used. The fluoroscopy will help you to exactly confirm your location, and you will expose the lateral aspect of the facet joint. One thing that I would like to mention here is that in the case of the open T-leaf, you will do the pedicle to pedicle exposure. While in the case of the MIS T-leaf, you are just going to remove the facet. You will not going to expose the pedicle to pedicle. And then the rest of the procedure is the same, that you are going to do the discectomy, preparing the end plates and placing the cage and the transpedicular screws. This diagrammatic picture will explain you more about the procedure. The surgeon will stand on the operating side, and the incision is marked at least 4 to 5 centimeter from the midline. Your focus will be on the facet. You will be around 4 to 5 centimeter from the midline in order to access to the facets and then surgical decompression of the lamina or the required areas. So, Dr. Adil, what can you see over this dilator? What is this structure? Can you narrate it for us?
Sir,
You have made the incision. You have made the incision around 4 centimeters from the midline. You have incised the fascia. You have passed through the multifidus isthmus, and you your dilator and brought your microscope in. So, what these structures that you will see on the microscope?
So, in the small picture shown above, it can be lamina, but in the main picture,
No,
with
no,
L4,
just this one. Tell us this one.
so this may be facet joints.
Okay, so it will be a set of okay,
L4 inferior facet,
and this will be the
L5 superior facet.
L5 superior facet. Well done. So then we are done this microscopic visualization, as Adil mentioned, that this will be the L4 inferior facet articular process. This will be the superior of the L5. The facet capsule is opened. It is removed with the help of the drill machine. This point is much important, that when you have removed the inferior facet of L4, you will move the superior facet of L5, but make sure that you will not damage the pedicle. You will dissect it down to the superior border of the pedicle. Afterwards, what you can see here. Yes, Nasirul Haq.
Ligamentum flavum.
So here is the ligamentum flavum, and you are going to remove the ligamentum flavum to expose what you can see here. Which triangle?
Sorry, Dr. Usman, I am stopping you. Madhya raised the hand. Madhya is, you are not saying because the status of raised hand. So Madhya want to ask, I think, at this point. If you want to take the
Yes.
question first, or you
Yes, yes. Yes, Madhya.
So my question is, how much percentage of the facet are we going to like excise? Is it complete facetectomy at that level?
Look, we are going to do the transpedicular screws at both sides. In the T-leaf procedure, we are going to do the transpedicular screw fixation as well. So number one, there is no harm in removing the facet. The main question is that which pathology you are going to address. You can remove the partial facet or you can remove the complete facet. There's no problem, because you are going to do the interbody fusion. You are going to have the 4 screws. So no chances of instability after the T-leaf procedure. The main aim is that you must address the pathology. If you are going to do the complete discectomy, then you can remove the complete facet. If you are going to just address the spondylolisthesis or just a small piece of the disc, you can do it with the partial facet.
So does this partial facetectomy will cause any hindrance in our like placement of the spacer or the bone graft?
Yes, it can create a hurdle, but it all depends on your operative findings. And if you are comfortable with the minimal invasive work, you have done your adequate decompression, and you can place your smart cages, which most of the time they are expandable cages. So when you put the small cage inside, you can expand it to the larger side of your desired range. So if you can done the procedure, you can done the decompression with the partial facetectomy, you should go for it. Otherwise, you can do the complete facetectomy. There is no chances of instability after this one, because you have to put the transpedicular screws as well.
Okay, sir. Thank you.
So, Dr. Zubair, can you just repeat the Camden's triangle? This one will be
This one will be this will be transversing nerve root, and base will be pedicle.
Okay, so we are done with the complete exposure. We have reached the disc, and then the same routine procedure of the discectomy creating the complete space, making the end plate preparation, filling the graft, the cage with the bone graft, and then placing it on its position. What are the complications of this MIS TLIF procedure? That can be the injury, but how can we avoid this nerve root injury? By medial and the lateral location appreciation, by identifying the traversing and the exiting nerve roots. It can be the cage misplacement, so you should do the careful end plate preparation and cage. If you're doing on the one side, then the cage must cross the midline. If you are doing on the both sides, then you will place the two cages on both sides. Pseudo-orthosis can be there, or the CSF leakage can as well.
Sir, but is it possible to, considering the size of the cage, is it possible to place the cage through the tubular system in TLIF and minimally invasive?
Yes, it is possible. The TLIF means interbody fusion. You have to place the cage. You have to.
Sir, but in the minimally invasive, the size of the cage which we are going to place, that will be quite bigger considering the tubular system we are going to apply for the surgical purpose.
Actually, we have to keep in our mind that the discs they are not of the 2, 3, or 4 centimeter. The normal disc height is only 1 to 1.5 centimeters. So we have all the range of the cages, the peak cages, they are available, and some of the expandable cages are available that you just put the cage inside, then you expand it, and it will give you the appropriate height. So that's not a big issue. That you have the complete range of the cages, they are available according to the tubular system that we are going to use. Even nowadays, the people are using the endoscopes. As you have seen so many times that we are doing the endoscopic discectomies, they place the cage through the same tubes, tubular retractors. This article was published, which shows the use of this retractor system, and you can see the so many rods, so many things that you have to keep in place in order to reach this TLIF. But with the passage of time, the tubular retractors, they have resolved this issue. One of the trial, now you will, I will be taking you through the few trials, few studies, and few research, recent advances in this MIS TLIF. One is the MESOS trial. It's still under study, which is going to look for the efficacy of this MIS surgery over the open surgery. As I mentioned earlier, that this TLIF or the MIS transpedicular screws, they are used by the people for as an adjunctive procedure. Like they do open PLIF, open lumbar interbody fusion, open oblique interbody fusions, and then they use the MIS transpedicular screws. Here I will like to show you the few examples. Like in this lady, she was having this sagittal deformity. So she underwent OLIF from L1 to L5 and L5S1. But she also underwent the posterior fixation with the help of the percutaneous pedicle screws. So people are trying to avoid the muscle trauma as much as they can. And in this case, she was having also the sagittal deformity, and she underwent the lateral lumbar interbody fusion from D12 to L1, OLIF from L1 to L5, TLIF from L5 to S1. But the posterior fixation was done percutaneously. This thing that can also be done with the help of this MIS surgery, that you already have the fenestrated screws. So you can augment them with the help of the bone cement in the cases of the osteoporosis. The OARM navigation is nowadays used for this percutaneous short segment pedicle instrumentation. These are the few images that, like, we have an arrow system. The other one is the OARM intraoperative CT scan. You get the CT scan, transfer it to the your navigation tool, and then do the fixation with the help of the neuronavigation. Now coming to another interesting paper of that shows the history of the retractor technologies of this percutaneous pedicle screw fixations. As you know that in the open procedure, you have to do excessive muscle work, but this tubular retractor has avoided this excessive muscle work. This was the one of the initial the rod systems that used another separate incision. You have to give a separate incision to move this rod in this rod applicator through these screws. These are the various tubular retractor. This one is the standard one, and nowadays the malleable retractor, they are also available. And this one is the flat retractor that is also available, that you can do the surgery with full ease. This retractor system, it is having an extra thread inside the screw, which will capture the rod and will gradually reduce the deformity. Here you can see that these were the initial rod systems, the initial tubular systems that were very much difficult to handle, and they have been replaced by the simple tubular retractors that we have nowadays. L5S1 MIS fixations, they are done almost with the single incision, and for that, the use of these they are quite cumbersome. So after the development of this malleable retractor system, the L5S1 fixation have become much easier. The various different tubular systems can be used in the same surgery as well. Bone cement augmentation can be done through these tubular retractors. This another retractor system that was developed is the wings retractor concept. It is a malleable retractor, and it helps in the L5S1 fixation. Now, Dr. Hasnan, I think he has recently joined us. Hasnan, are you there?
Yes, sir. Can you hear
Okay.
me?
Yes.
Sir, one
So
question I had also.
yeah.
Yes, that you have said what I want to ask is there's the book says there's a variation in the when you are fixing the screws or whatever, that up to 25% there's variation between like when you are doing the imaging on the CT scan as compared to fluoroscopy. So uh, speaking from a practical standpoint, excluding the time spent in the CT and whatever, so the intra-op CT will not give us an added advantage over fluoroscopy if we are utilizing that.
Look, the intraoperative CT has its benefit in the terms of when you are going to use it as an adjunct to the navigation. That you done the CT, you transfer the data to the navigation, you did the procedure, and then you again confirm your position. The CM will help you to put the screws, but CM will not give you the 3D picture. The per-operative 3D picture will be with the help of the intraoperative CT.
But if there is a 25% variation, or in you've done 4 patients, for example, in one of them, if you have that, yeah, how I'm interpreting it. So when will this variation be retained when you transfer the data to the neuron? Can you understand what I'm trying to say? That what do you understand what I'm trying to say? Like if there's a variation,
So I think
so
it means
suppose
that the CM data and the intra-op CT data when will be transferred to the neuro navigation. So there will be malalignment due to the misinterpretation of data and 25% difference of the parameters or the measurement, 25% difference of measurements between the two intra-op modalities we are going to use for the images.
Look, we are going to use intraoperative CT only for the data pre-operatively, then send it to the navigation system, do the rest of the procedure with the navigation, and then again, before extubating the patient, we are getting the intraoperative CT again. This is one thing. The other thing, that if we are just using the CM, this is separate. This is entirely a separate thing. We cannot mix both of them together.
okay.
Is that clear to you?
Yes, sir.
Okay, so can you just read the this topic, this this paper that has been published?
This is a mini open transpedicular lumbar vertebrectomy reconstructed with double cages and short segment fixation.
So what do you get from this? That what is the transpedicular lumbar vertebrectomy? Just be open, if you can just think
So,
over
sir,
it.
there will be, we could removal of the vertebral body, basically.
Yes.
Of the vertebrae, basically, by the mini open, there will be a smaller incision than what we give in routine, and with the double cages to replace basically the vertebrae that has been removed, and then there will be a short segment fixation, meaning one level above and one below, basically.
So I would like to highlight one thing here is that they have done the transpedicular corpectomy. This is
Yes.
the removal of the vertebral body from behind.
Yes, sir.
The other techniques that the lateral lumbar interbody fusion or the olive, they remove the vertebral body from the side. They have to do the excessive the muscle work, go retroperitoneally or through the transperitoneal. While in this procedure, they are just and through the pedicle, they are going to remove the whole of the vertebral body and fixing it with the help of the cages. So this is another way of doing the pectomies, that you are going to do it through transpedicular route. And then you can further augment it with the help of the percutaneous transpedicular screws. This study was done to compare the OARM used navigation and microscope assisted MIS T-leaf with the conventional open T-leaf, and it showed that they are having the convincing results for this MIS T-leaf. These are the few operative pictures of that procedure. As I mentioned that initially, that the spinal instability of any kind in MIS surgery can be done. So this paper, it showed that the even this MIS surgery is of advantage in the tuberculosis. What they have done, they decompress it with the help of the endoscope and then fix it percutaneously. So this is another paper that was published in India, and they have created their own.
Yes, please start.
Okay. So another research paper that was published in India, that it showed the NIMS technique for the MIS spine fixation. They have created their own technique for that. What they did, that they followed the same protocol of passing the Jamshedi needle, the guide wires, the dilator, and the cannulated tap screws. But then they removed all these things and used the non-fenestrated pedicle screws. They used it with the just a freehand technique. As the pilot hole has been made, they confirmed it again with the help of this CM, and they used the non-fenestrated pedicle screws. For that, they were cost effective. Actually, the basic theme behind them was the cost effectiveness. The fenestrated pedicle screws for the single procedure, that cost them 130,000 Indian rupees. But when they used only the non-fenestrated pedicle screws, the cost reduced to the 32,000. So this thing people are trying to do, and that can be possible anywhere. This data was published in 2019. The updated meta-analysis, which showed that the MIS T-leaf is showing good results, and it is a comparative procedure to the open T-leaf. This procedure was published in 2019, and they have done almost 200 cases. And I would like Dr. Irfan to just read the title of this research article.
Yes, sir.
Yes.
Endoscopic transforaminal lumbar interbody fusion without general anesthesia. Technical innovations and outcomes.
What you get from this heading, Irfan?
Sir, they have tried endoscopic transforaminal lumbar interbody fusion without GA, means with sedation or with some local anesthesia.
So you want to say that it is the same contemporary to the awake craniotomy? This is an awake
Yes,
T-leaf?
it seems like that.
Yes, they have done it. They have done almost 200 awake T-leaf procedures.
Okay.
Technique that they sedate the patient, the endoscopic visualization, the procedure under the endoscope, placement of the expandable interbody devices, and then with the help of the long-acting local analgesia, the percutaneous instrumentation. So people are doing this thing as well. So for being resident, you should know all the recent advances of any procedure.
So
Uh,
what is the added benefit of this like awake sort of spinal fixation?
See, they claim that this the improvement in the outcomes both in the acute and the long-term recovery periods, but it's still under study, and they are just doing it for the more cases to come up with the good statistical results. But this thing they are doing, and for being with the residents, and they must know that these are the procedures that are going around all over the world. And the next one
Or
is for
Just before going to further, I just want to add one comment. Some people in Pakistan even doing the discectomies in the local anesthesia in the lateral position. In many centers, even in Faisalabad, it is a very common routine practice. So doing a lumbar spinal surgeries in a local anesthesia is not new. In Pakistan, it is also practiced. But
yes.
in our center or in good centers, because especially the muscle dissection is very painful thing from the periosteum. But in MIS, it may be less painful because muscle stripping and muscle damage is less. Uh, but this is just the comment, and I am not favoring that we should do the such procedure in the local anesthesia because it does cause discomfort for the patient. But if patient is unfit for general anesthesia due to some reason and surgery is very mandatory, so it may be an option in such cases. It was just my comment. No favoring this thing or the other thing.
So the next paper was published for Dr. Hasnan in 2019. Yes, Hasnan, are you there with us?
Yes, sir. Yes, sir.
So can
The
you read
use
it?
of robotics in minimally invasive spine surgery.
So there are a few papers that have been published in the 2019, and they claim that the accuracy of these robot-assisted percutaneous pedicle screw placement, they are giving the same results or even the by better results than the routine MIS. So the FDA approved various these the robotic instruments. The first one was the Mesorex surgical system, and it used the calibrated fluoroscopic robotic arm. While the later on, another one, the Excelsis GPS surgical system was developed, and this system guides the pedicle screw insert in the lumbar spine surgery in the form of the MIS as well. And this was the T-lift procedure that was done robot assisted. Coming to the MIS procedures that have been done at our center, we have done at least almost 10 MIS transpedicular screw fixation, and we did almost all type of the AO fracture classification, including even the A3, the A4, and I would like to mention here that we have even done the type C injuries as well. And all of the patients, they are having the same neurological status as preoperatively. These are the few images of our procedures that are done at our center. The MIS transpedicular screw fixations. And this is the X-ray that I want to discuss with the residents that what do you think, Madhya, that is this an accurate or precise AP X-ray? Dr. Madhya?
no, sir, not really. The left-sided X-ray is it should be equidistant from both the pedicle. It's not. It's more inclined towards the right side, and that's it, sir. And also,
This was the reason that X-ray in the last few slides of my presentation, that the screws have been placed perfectly fine in the lateral. It was confirmed later on with the help of the CT scan. preoperatively. This young guy, he was having a bit scoliotic preoperatively, and he was not knowing that even before the surgery, before his trauma. So you should keep thing as well in your mind. So here come the role of the SIAM user, that he is going to show the surgeon the exact picture, and then manipulate the SIAM to get the spinous process in the mid of both pedicles. This X-ray was done post-operatively, and it was a routine AP lateral view. So not knowing that he is having either some deformity and they have to rotate the X-ray film. Process, it should be in the mid of the pedicles, and especially in the translational injuries like this one, this patient, he was having as the translational element as well. For that, you have to focus on one vertebra first. You have to move the SIAM according to the one vertebra, according to the one pedicle, get it in the proper AP view, do the fixation, and then move to the other one.
Yes, sir, very much.
Okay. So this last slide is for Dr. Nasirul Haq. Dr. Nasirul Haq, are you with me or you are with the patients in the ward? I didn't join this last session. So Hasnan. Dr.
Yes, sir.
Hasnan.
Yes, sir. Sir, in this case,
Okay, just forget about the case. Just focus on the
number of X-rays. Number of X-rays.
Yes, good. You are talking about the SIAM, the intraoperative CT, and this and that. That's why I choose you to comment on this. Add this slide for this reason. So what you get from? Yes.
So from point of view of exposure
yes.
to the surgical team.
So in the first few cases, we even touched 200, and this the right side picture, which is showing the 125 X-rays, it is the final X-rays of this young man who underwent the percutaneous pedicular fixation, and we are able to reduce it to 125. So I'm hopeful that in the coming few months we can move to more. We can move to the less. So the last three short MCQs for you people, and I would like to all of you. It is important to do what? The cage higher than 13 millimeter, longer than 27 millimeter, using non-degradable interbody devices, or it cross the midline.
Cross the midline system.
Cross the midline.
Yes, Irfan.
I will go for option C, sir. Use no.
But I think that the best option is the cross the midline. You have to cross the midline when you are doing it from the one side. The cage must be crossing the midline, and it should give the vertebral body support on the both sides and as well as the midline. And then the additional support will be from the transpedicular screws.
So what about the height of the cage?
The height of the cage, it will be according to the templates, and you have done the end plate preparation, you have complete with the, when you're done with the discectomy, then you will place the templates first. Templates will help you and they will guide you that which cage is most appropriate. And you can even done it pre-operatively with the help of the intraoperative or with the help of the CT scan. So the second MCQ for a T-lift procedure at L3-4. The laminectomy is done at which level?
L3.
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 So where do you have same or you want to go for L4?
Why you have to do laminectomy for T-lift?
Yes, it's done in the case of the open T-lift or when you have to do the regression. Just
Okay.
an MCQ for them.
Okay. Okay. Okay.
G is bad.
Sir, L3.
Okay. All of you are correct or just following Adil and Madiha. The last MCQ and the last slide. When using the AP-based technique for the percutaneous pedicle cannulation, how far is the Jamshedi needle advanced before passing the medial pedicle wall?
3 centimeter.
3 centimeters.
3 centimeters, sir.
Okay.
30 mm.
I think Nasirul Haq is still missing.
No, sir, I am with you. It's 3 centimeters. Sir.
Okay, thank you, Nasir. So
Welcome, sir.
with that, the today discussion is done regarding the MIS transpedicular fixation and MIS T-lift. Now I would like to have the opinion and the comments from Dr. Saeed Shahzad Sahab and the rest of the fellows who want to add or add them more.
It was extremely nice presentation. The subject is explained in very easy way. For example, we are not doing these MIS periods, but now I think we can do it very easily.
आपकी आवाज नहीं आ रही सर, वो म्यूट किया हुआ है आपने.
जी म्यूट किया
हेलो.
जी
सॉरी,
yes,
मैं बोल रहा हूँ. So it was a very nice presentation. Dr. Sultan in like no, you know, I just want to do and he made it so easy.
Nasir, please mute your mic because both are using the same voice. Please mute your mic. Yes. Ji sir. Ji Dr. Shahzad, please proceed.
And I also appreciate the participation. People were interested, and the question answer session was. Hello, Dr. Nabil.
Ji, yes, we are hearing, but voice was jittery due to, I think, poor connection.
There is some problem. Do you want to say something?
I think it's enough for this. If participants have questions,
Yes,
Umar has raised the hand. Ji, Umar asked from anybody question.
Sir, thank you so much for allowing me, and sir, thank you so much for the presentation. Sir, my question is, sir, मेरा मतलब सवाल I don't know बनता है कि नहीं, क्योंकि मैं इतनी डिटेल में जानता नहीं, लेकिन मेरा क्वेश्चन है कि अगर मल्टीपल फ्रैक्चर्स हो डिफरेंट लेवल्स के ऊपर, तो सेम क्या कहते हैं टाइम के ऊपर हम दो जगह पे ये टीपी फिक्सेशन वगैरह करते हैं या नहीं, क्योंकि मेरे ज़हन में वैसे सवाल आ रहा था कि एक सर्जरी के दौरान दो या दो से ज्यादा टीपी फिक्सेशन होती हैं.
This technique is ideal for multiple levels. MIS तो बहुत इजी है इस हिसाब से ना कि आप अगर आप मल्टीपल जगह पे फ्रैक्चर्स हैं तो MIS आप कर सकते हैं. ओपन टीपी मतलब ज्यादा मुश्किल हो जाएगी, लेकिन MIS की जा सकती है.
मतलब एक ही वक्त एक ही टाइम के दौरान
एक ही सिटिंग में कर सकते हैं, बिकॉज सबसे इम्पोर्टेंट चीज जो है ना वो इसमें आपकी टाइम जो है ना वो बहुत रिड्यूस हो जाता है. with time
जी सर
अब MIS करने का मतलब है 35 minutes 40 minutes maximum 1 hour
जी
MIS
सर
जो open TP है takes 2 hours 2-3 hours तो उससे बहुत कम टाइम होता है तो MIS आप आराम से मल्टीपल लेवल पे कर सकते हैं more easily than open TP.
ओके थैंक यू सर सो मच
अच्छा नेक्स्ट फिर जी नेक्स्ट टॉपिक हमारा है MIS एंडोस्कोपिक सर्जरी एंडोस्कोपिक में एंडोस्कोपिक जो डिस्क है ये होगी और साथ सर्वाइकल फर्मनोटमी इस पे फिर नेक्स्ट सैटरडे डिस्कशन होगी फर्दर इस बारे में नबील साहब कुछ कहना चाहते हैं आप
Yes, it was a very nice presentation. Different concepts and different ideas, they were made clear. So it was very good for the beginner as well as the consultant level for this, Dr. Usman. Thank you very much. Just as Dr. Usman has mentioned that before beginning this MIS surgery, a person must have a good knowledge of the anatomy as well as the experience and knowledge of the open technique. So open technique is mandatory. Might be this generation need this because as we have seen in laparoscopic procedures, because it was initially said that every laparoscopic surgeon should be familiar with the open techniques, but now the generations are coming up that they have not performed the open techniques. Similarly, for this generation, this we are passing through the transit from open to the minimally invasive surgery. So this generation may require both of techniques well familiar, but might be in future, many generations have not even seen the might be the open techniques because they will be well versed and starting from their launching pad will be higher than this generation. So, but for now, we should be familiar with the open techniques. When there are complications, when there are problems, we have to convert it into open one. So we have seen in our unit, it is decreasing day by day for our beginners. For open techniques are becoming less. So there are different videos, and whenever they have opportunity to practice, yes, the junior consultants and the PGs, you must have both have the idea of open as well as the minimally invasive surgery. Yes, Madhiya, you have raised the yes.
Sir, I'm still surprised by the fact that how come the functional outcome after an MIS TP fixation is equivalent to an open TP fixation where we are doing an where we are using a bone graft as well. But if papers are saying and research is saying that both have the same functional outcome, then why we are using this our orthodiscs in open TP fixation? Then we should avoid it in open TP fixation as well.
Yes.
This is the one of the
Very good
major
question.
concern. This is
And
the one of the
people
major
discuss it
concern.
and even
Ji, Dr. Usman, please proceed. Yes.
they just say that it is like external fixation. MIS is just like you place an external fixator, you can remove it after 6 months or a year. So it will not give that fusion effect, that union which we can get by fusion and by open TP fixation. This is a reality. So we basically initially it was decided that it should be used in those cases where we don't require fusion. For example, minimal fractures, there is instability, but minimal instability, or the patients who are paraplegic, who are completely paraplegic, who are not going to overcome that deficit. So it is a definite concern. So it must be limited to the persons where there is a minimal instability. Number two, who are completely paraplegic. Dr. Swan.
Yes, the same comments that this was a big question on the MIS TP fixation, that we are not going to do the fusion. That was the reason that they developed these side speculum retractors where the bony fusion or the bone material that can be placed. So, but this thing is still under study, and results are still to come for this reason.
So, sir, one question. Suppose that you are doing MIS and you have this speculum for placing the bone graft. One, since you are doing MIS, where you will get the bone graft, and will you like, because we are placing it usually along the length of the rod, usually when we are doing open TP. So how there.
People are using the autologous, the boon, the BMP, the boon morphogenic proteins, or the things like that have been available artificially. They use these things for this bony orthodesis, because for getting the bone from the MIS area is not possible.
That's
Sir, earlier we were talking about are there any contraindications for this minimally invasive procedure in this case? Because we have discussed the indications, but any absolute contraindications or relative contraindications for this?
Look, there are people say that if the patient is having neurological deficit, or he is having the A4 compression fracture, the complete burst fracture, then the patient needs the decompression. But these MIS-TP fixation, or these people, they have some kind of answer to that one, as if the ligament or the posterior ligamental complex is intact, then with the help of the internal reduction or the distractor, the ligamentotexis can be achieved. But it varies from case to case. So for those patients who are having the neurological deficit, or having the complete type 4, A4 burst fracture, they should be done open. But we are in the process of doing the TP fixation for these patients. We are the research paper that we are going to conduct. We are in the phase of focusing on the neurological deficit improvement as well, as we are doing on both patients. We're doing in the complete paraplegic as well as the patient who are having the partial neurological deficit. So let's see what comes up with us over the next 6 months to 1 year, and then we can get an appropriate answer for that, whether the ligamentotexis and the distraction with the help of this MIS-TP can improve the neurological deficit. Then this MIS-TP can be done for these patients as well.
Okay.
Sir, my question is, first question is that, if we want to do distraction in MIS cases, can we perform it? Can we do distraction in these cases?
Yes, we can perform. As I told you that these implants, they vary around the globe. The implant that we are using in our department, it has its internal distractor. The main thing is the tulip of that screw that I showed you in one of the paper. These tulips, the distractor, they fix on that tulips, and then you can do the distraction and then tighten the screw. You can do the distraction with the help of this MIS.
Okay, sir. Sir, another question is, what are the immediate follow-up of these cases, and what are the long-term follow-up for these patients?
Look, these things, people have published their papers on the short-term outcome and the long-term outcome, and they claim that this MIS-TP is having over the open TP, especially in the short term, that there is a shorter hospital stay, there is the early mobilization, and the less infection chances with the this MIS procedure. But the long-term outcome, they are still yet to be confirmed, that whether they are having the same result as that of the open TP or not. And the study that we are conducting, we are calculating the ODI score for this MIS-TP fixation up to the 6 months. So let's see what the results come, and then we can be sure that the functional outcome of MIS-TP is comparable with the open TP or not.
Thank you, sir.
So thank you, everybody. Thank you, Dr. Usman. It was really a nice presentation. So inshallah, hope for the next Saturday. We will try to remain precise and to remain in time. This 2-3 hours is too much time. So we should try to complete it in one session or maximum by 2 sessions. So 40 and 40, 80 minutes are enough, I think. So goodbye,
Okay.
everyone.
Okay.
Thank you for
sir.
participation.
Thank you.
Thank you, Dr. Usman. Thank you, Nabil sir.
Thank you.
Thank you,
Bye.
sir.
Thank you, sir.